right, you guys all ready?
Ready.
Questions and
All
answers.
right, let's. I'm going to start over here, right over here.
Hi, good morning.
Morning.
I'm actually a primary care PA, and I'm interested in going into emergency medicines, which is why I came. And I really appreciate everything you guys has taught me today. I really do appreciate that. But my question, you mentioned about hyponatremia and knowing the volume. How do I know if they're hypovolemic?
It's usually clinically completely obvious. And it's
just
based
looking
on
at
your good physical exam, which you know how to do. So peripheral edema, ascites, evidence of congestive heart failure, they're usually hypervolemic. If they're tachycardic and their mucous membranes are dry, they're hypovolemic. And otherwise, it's usually euvolemic. And you use your clinical judgment that you know how to do from having done your physical exam. So trust your judgment on that. And it's just when you look at them, is there too much fluid, not enough fluid, just right?
Okay.
Yeah, you know how to do it.
Okay, just checking. Thank
Yep.
you.
You bet. Over here on the left.
Hi, good morning. I have a question. I work in an inner city ER, and in the ER is always a rush for patient flow. Move the patient, move the patient. So we have a new ambulatory zone where they created stalls with chairs. So it's more chairs than beds. So I wanted to know, what's your opinion about examining back pains in a chair? Like, how does that hold up in court? Because I get a lot of people that roll eyes at me when I ask the patient to be placed in a bed versus a chair. And I hear some providers that say, oh, Jennifer, you can do an exam in a chair. But I just want to know your opinion about that.
Oh, for God's sake.
Well, I think you can do it in the chair as long as you take all her clothes off.
There you go. Yeah, just strip them down right there in the chair.
No.
So I get this whole idea of move the meat, get it out there, get faster. But seriously, we are medical practitioners doing a very important job with you and a patient. That is nuts. That is nuts. Stand your ground. Okay, stand your ground. It's important to do. A back pain can be so many. It could be zoster. How are you gonna know if it's zoster if you're looking at them in a chair? So you really have to have their clothes off. It's crazy. We have the same thing. And be careful asking questions in a chair. We got cited for a lack of privacy issue. Don't do it. Take them somewhere private.
Oh yeah, everybody knows your business in the
Crazy.
chairs.
Oh, it's crazy.
They
Well,
have like a little, it's like a
yeah,
stall,
well, just
like a
hope,
bathroom
hope
stall.
the Joint Commission doesn't come by your ER because you will get cited. It's one of their major things right now is patient privacy.
They did do
Yeah.
better with the asthma room. We used to have an asthma room where it's just oxygen
Yeah,
and
yeah.
free air, and everybody's in this one room.
It's
They
nice
changed-
because then all the beta agonists are in that room, so everybody's breathing in together. So everybody's getting treated.
Very good.
Stand your ground.
Yeah, seriously, don't let them denigrate what you do for a job. You got it. Ugh.
Very good. Let's go over here.
This is a question on electrolyte. I'm a primary care physician, and we get lab results on patients with potassium.
All the time.
High potassium. These are patients at home. And I want to know at what number, 6.5 and above, when I send them to ER.
You know,
or
this is right. So this is
bring
the
them.
conundrum for those of you that work. We get this all the time in the ER. Why are you here today? Because the potassium they drew on Monday, it's now Thursday, was 6.5. So I recheck them in the ER. It's fine. We send them home. You're stuck in a bind with that. If the tests come back abnormal, you can't ignore that. So you have a couple of options. If you have a rapid, chemical, you can do your own point of care. You could bring them back to your office and check them there. They haven't died in the interim, so whatever they had hasn't killed them. And if you get them on the phone, but honestly, if I were you, I would not take risks from the phone from a lab. If you have a concern, bring them back to see you or send them to the ER. Potassiums, you got to be careful with potassiums, especially somebody who's on an ACE inhibitor or is a dialysis patient. You have to be careful.
Right.
So don't take the risk. If you're worried, just either send them in or bring them back to your office and check it again.
Question really is like when to send them to ER.
Yeah.
What number? Like
There's not a
you
number,
know,
okay? You can't
no
base it on
number?
a number per se, because it depends on the patient, right? A potassium of 5.8 in a renal failure patient may be not that big a deal, but in somebody who just started on an ACE inhibitor, it might be. So I can't tell you there's a number that's magic.
I see. Like, do I bring them to office, do EKG, because that's
You
all
could.
I can do.
Actually, you
and
absolutely
then-
could. That's a
right,
very good idea.
And then decide, like when to send them to ER, because I can't do insulin, glucose,
Right.
calcium, and all that stuff.
Yeah, this is one of those issues that comes up that's office-based that I can't give you a clear answer for, but if you're worried, that's why we're there.
And I think it's important. The other question, I always ask the lab, is it hemolyzed? Because they don't always want to volunteer that information. And the EKG is great, but not everybody will get EKG changes, even with a hyperkalemia. So I don't know the percentage, like 30%.
Yeah, I certainly wouldn't
So
depend on
EKG is
that.
good, but not 100% accurate to say that they're not hyper-K.
But it does tell you their heart's okay.
Very good. Okay, over here. Yes, sir.
Yeah. For Dr. Danielson, if a senior citizen presents with zoster, should you screen him in some manner for an underlying malignancy, particularly a lymphoma or a myeloma? And if a younger person presents who maybe is sexually active or a drug user or both, should you get an HIV test?
Well,
That's for you, I think.
I think the answer is, I think the first question was, if a senior citizen comes in with zoster, should you look for an underlying, some other pathology? Was that the question?
Malignancy.
Malignancy.
Suppressive malignancy.
I think an older person, it isn't necessary because just the immunosenescence of getting older. Having zoster when you're an older person doesn't correlate with cancer. It correlates with immunosenescence, meaning that your immune system just is getting old and isn't quite as good. But your other comment is right on target. If you see zoster in a 25-year-old, get an HIV test. Because that 25-year-old shouldn't be, they're not immunosenescent. They have no reason to have that zoster pop out. They may just be unlucky, but that is a really, really good point to look for some sort of immunocompromise.
Very good.
And what about all of these baby boomers who have hepatitis B? You see the stats on that?
Yeah, I don't know. I don't know what to do about that.
All right, back over here.
I actually have two questions. The first involves tooth loss. Oftentimes these patients come in on Friday afternoon, late. What is my medical legal responsibility regarding referral? Because oftentimes these patients have no insurance. There is no dentist on call in any of the local hospitals where I work. Could someone speak to the medical legal responsibility of that, especially if it's a cosmetic issue?
It seems that all you could do is the best for the patient, and
Best you
within the system that you work, you can give them antibiotics and if it's IND-able, you can do that. You can
Talk about a Volz tooth?
Yes.
Yeah, so the tooth is out, you stick it back in, you co-pack it the best you can, you cross your fingers, and they need it.
Oh yeah, I didn't catch it as an avulsed tooth.
Yeah.
So basically, you do just the things I said. I think that you try to stabilize it with some kind of stitch. We don't have a lot of good stuff. There are things that the dentists use that maybe we could learn how to use them in
I
terms
do
of
recommend learning how to
stabilizing.
use co-pack. It's epoxy. It's easy. You put the two things together, you slam it on both sides of the tooth, have it attached to the next two next to it. It's perfect. It stays there. It's great, but it's not permanent.
Gotcha.
They need to have that thing replanted for real. But that at least is a nice temporizing measure. And I have to tell you, it's probably a several days temporizing measure if you do it well. And then give them a list of dentists and a phone. Say, here's your cell phone, here's the list, good on you. And if you have people you can call, great. But if you don't, at least you give them a resource.
So
My second question involves the evaluation of back pain. When would an MRI with contrast be indicated?
Oh, I sure don't know. From the point of view of an emergency physician, I don't think any of our MRIs use contrast in terms of trying to pick up these infections or these cord injuries or maybe. Do you have any sense of that?
For what we need, it's virtually never. Even for the abscesses and the discitis and all those things that we worry about that are really truly cord threatening, they'll pick that up on a regular MR. Later, if they want more specifics, they can get you don't need, which is nice because gadolinium you have to worry about creatinines and the whole shebang. So you don't have to worry about it.
All righty, over here.
My question has to do with nasal fracture. If you have a nasal fracture and you see a septal hematoma, is that something that you drain there, and could you talk about, or do you refer to bring in the ENT to drain that, and how do you do it if you're going to drain it? And I have one quick other question.
yeah, most of the ones I run into, ENT usually wants to do it themselves. And I usually talk to them, and in my setting, do they want me to drain it or they want to drain it? And usually they'll drain it and see they're in the ED or in the office. But I have drained one before and then packed to prevent the recollection and have them follow back up. But I usually let the ENT make that decision. Do they want to do it or me do it? But make sure if we do drain it just with a syringe and a butterfly needle usually works pretty well, that we've packed it to prevent the reaccumulation.
Yeah, a couple things about it. If you do drain it and you use a needle, you have to make sure you got it. So part of it is to make sure that you actually drained it. We actually use the point of an 11-blade scalpel. And you can do it yourself, absolutely can do it yourself, but packing is the key. It's just like an ear hematoma. The dressing is what's going to make it, once you drain it, it's the dressing that will keep it from reaccumulating. Same thing with the nose. It's the packing that will keep it from coming back. And it's not hard to do.
And what are you packing it with? Are you just using?
Aha. So what do you use?
I've used the nasal tampons before, just to put it up in there, and it absorbs what moist is there and works. And even sinus regular gauze packing, like the 1/2 inch to inch, just to get up in there and get enough pressure, and it's just pushing up its the septum and keeps it from reaccumulating.
Yeah, it's interesting. I love we use Miracell as the brand name, but it's basically the nasal tampons. The only thing I don't know about those in this instance is how much pressure you really get from that. If you ever take one out and just get it wet, it's really squishy. It doesn't have a lot of pressure that it's putting, and I worry a little bit about whether that's enough pressure against the septum to really prevent reaccumulation. So I tend to err on the side of either using a rhino-rocket, the front balloon only, or using the old-fashioned packing.
Okay.
It's just the old-fashioned stuff. It's a bloody mess, by the way, just as an aside.
And my second question is another procedural one. So if you're doing your hemorrhoidal, your hemorrhoid clot excision, you mentioned using local anesthetic. The slide mentioned anesthetize the base. Do you anesthetize right on top of the hemorrhoid?
I anesthetize where I cut.
Yeah, that's
on
what
that
I've-
one. And the other thing to make that an easier procedure, I highly recommend the knee-chest position. Make sure they're dignified, but basically it's face down, butt up. And what happens with that is the cheeks will separate automatically, so they can't do that clenching down thing, which is like, prying of trying to just have them. But I keep a sheet over till the last minute, tell them exactly why I'm doing what I'm doing. Then it's like, okay, it's going to be quick, I promise. Sheets up, I'm doing my anesthesia, I'm taking out the lips. Oh, there's the clot, it's wonderful. Sheet down. Because people feel real weird, their butt up in the air. But it really does help you get that done quickly with the patient's dignity, and there's no trying to lift them sideways, and it's just a much better position.
Thank you.
You bet. Over here.
Two brief questions. The first, is there any contraindication to mixing lidocaine and bupivacaine in the same syringe?
I don't think so, as long as you're sure your dose.
Okay. The second question is, I just recently saw my very first case of uveitis in a gentleman, came in massive sore throat, low-grade fever. Tonsils were fine, peritonsils were fine, but his uvula was about the size of my middle finger. And other than covering oropharyngeal organisms and steroids, what else is distinct about an isolated uveitis that I need to worry about other than airway compromise compared to your other regular pharyngitis, tonsillitis, et cetera?
I don't think anything. I think most of them are viral, actually. So antibiotics are fine, but I think most of them are viral. And the hardest thing about it for the patient, the steroids, I think, are where the money is on this one. And the hardest thing for the patient is that they feel like they're choking.
Yeah.
Because this thing is basically hitting their gag center over and over and over again. So they feel like they're choking. Their airway is hardly ever compromised from that because it's very mobile, it's very squishy. The thing doesn't usually get hard. It's smushy, so it doesn't usually cause a huge amount
You
of
may want to consider cutting off the lower third.
Tourniquet technique?
That's it.
Thank you.
All right, thank you. Over here.
Yes, I have a kind of a two-part question, but only one question. When we sew people up, we want to make sure that their wound does not get infected and all, and proper cleaning and irrigation. But I know there's so many different ways to do that now. Is there a standard guideline? A lot of the rural hospitals I work in, they can't afford a lot of the really prepackaged cleaners, so to speak. So we have Hibiclens, betadine, and saline. So now the move is saline. So I'm wondering, is there a standard that we should be using for that? I mean, we have surgeons now who insist that everything be cleaned in betadine before it's sewed up. And we're still battling those guys. So, and the other thing is burn.
How old are they?
They're older surgeons.
Yeah, because the literature
Yeah.
has been for quite a while now.
Right.
It's basically said betadine's not so
Right.
fabulous.
But we have the betadine scrub and the Hibiclens scrub, or we have saline. And the other part of this question is for burn care. What's the recommended cleansing for that as well?
I think the best thing for the lacerations, of course, is the Hibiclens around the wound edges, not in the wound itself. And irrigate with saline is one of the best things. And whether it's the liter of saline with the 18-gauge needle, which I've done for years, and now we have the little caps that go on the top of it, but the high-pressure saline to wash it out is the best thing to make sure we've removed all visible contaminants. Works really well.
Although there's literature that says take them to the sink.
Yes.
Yeah, we have a couple of
And have 'em
papers that
wash it
say,
out.
go to the sink. And obviously, you see some of these wounds where the guy was working in his car and the wrench slipped and they cut the top of his knuckle, but the entire hand is greased. That person needs to go to the sink after they've been anesthetized so they can soap and water, clean that thing up. One of the things you do have to be careful of is trying to prevent that person from fainting, because some people do. And I'm familiar with a legal case where a guy fainted at the sink, hit his head, and had permanent neurologic sequelae out of that. So I think they need to have a seatbelt on the chair, But I think also it's probably a reasonable thing to do to have somebody be with the patient. If it's a tech, that would be great, because that is a risk. But there's no question, and in fact, I think this compared sink with other stuff, and sink won. And there's nothing in tap water. There's no bugs in tap water. It's perfectly fine.
Yeah, there was a study a couple of years ago. They looked at sterile saline versus just tap water, and there was no difference in the infection rate. And they actually even looked at sterile gloves versus aseptic technique. And as long as it's not badly contaminated, they're pretty clean. And tap water works great.
How many of you have cut yourself at home? You go to the sink, you wash it out, you take a Band-Aid and you basically turn, because who wants the damn stitches? Seriously, you tourniquet the heck. I took the entire tip off my thumb, stuck it back on there, washed it like crazy, stuck it back on there, Band-Aided the heck out of it, and never went in for stitches, and nothing got infected. They don't. So saline is fine, actually, or water is fine, sink water is fine. And the magic is copious. The word on your chart is copious. Don't put 100 cc's, 1,000 cc's, because if it's infected, it's never enough, right? You should have done more. So just put copious irrigation, copious cleaning, blah, then you're fine, you're covered.
And burn care,
For which kind of burn?
just like, say, a second-degree burn.
So a blistered burn.
Yes.
What do you guys do with blisters? Blisters, I swear to God, the pendulum's like, open them, close them, open them, close them. Wow, what do you guys do?
Most of our burn guys like to leave them closed for the first 24, 48, and then they'll open themselves up and debride them themselves. So I usually do saline dressing, dry dressing on top. Saline cleanse, dry dressing on top, and let burn take care of
Yeah,
that.
the saline cleanse is probably, it's not really an aggressive way to do it, because, it hurts. So you can't really do a lot of stuff. You just kind of assume that it's more or less going to be clean. It's hard to dress blisters. You're dressing bubbles. So, and those blisters are ultimately going to be broken either naturally or by you. So, sometimes to get it move it ahead quicker, I break them. I don't tell anybody.
Yeah.
It's all-
And if they're open, if they're small enough, or you have the big enough ones, the bio-occlusive dressings are awesome.
Right, and
They're
you can't
awesome.
You can't
Just
put
it
those
right
down
over the
on
wound.
top of
you
a
can
blister.
see it. It's a template for the fibroblasts to grow on. You can see if there's any risk of infection. It protects it from air, which hurts so much.
Okay.
It's wonderful. Those are
Thank
awesome.
you.
You bet. Over here.
Just curious for your comments about perirectal abscesses in the ER.
Surgery, operating room.
Seriously.
Yep.
The differentiation for us is it coming from the perirectal area, which means it involves a rectal exam, or a very good exam to see, or is it perianal? Because technically speaking, if it's outside of the anal verge, it's actually outside the anus itself, but in, sort of on the cheek of the buttock, theoretically, those are something that we can do. The key is to make sure it's not coming from above and tracking down. So you have to do a good rectal exam and see. And if you think it's perirectal, or you have a question and you've scanned it and it shows to be perirectal, that's a surgeon's job.
And the same thing with pilonidal cysts, that get infected. They can be a real mess. Some of them are huge.
Yeah.
We do those though.
Very good. Over here.
Yes, I work in a fast track in a hospital, and I do see a lot of dental, mostly caries. But the question I have is, when should I get an X-ray of someone that has a periapical, or I think that has a periapical abscess?
Why would you do? What is it going to change?
Well, that's what I'm asking. I saw it. I had never seen it until this morning, but
Don't bother. Just treat it.
Yeah, the only time to be worried is if it has gone beyond what should be related to the tooth. So you have a big odontogenic abscess that's now tracking down into the neck. Now you're getting into that's a different entity. That starts at the tooth, but now you're dealing with a bigger infection. Most periapical abscesses are right at the bottom of that tooth. The best way to treat the pain, I think, is to just do a block. That way you don't have to give them narcs or anything. You just do a block like your dentist would do.
Marking. Well,
Marking
you don't even have to do a block, because a block is going to take out.
No,
if you do a block, it's going to, depending on where it is.
At the base of the individual tooth.
Yes.
Whatever
that's-
tooth is
That's
involved.
what I was going to say.
Yeah.
Each individual tooth can be blocked.
Great,
Works
thank
great.
you.
You bet. Over here.
Yes, I was wondering what source you're using for the metronidazole and the periapical abscess or abscesses.
The
The source.
the source.
The source for research that you're using that versus, because I know several endodontists that lecture nationally and they've never told me to use metronidazole. Just curious.
I will easily find you, and you'll find it. If you go into the internet, you'll find it. It's the,
Have her email you, because he can pull it from the database and send it to you. I did
Okay.
that for a couple people, and they were asked another question related to some antibiotics things.
Okay.
If you email him, he can pull it off the database and just send you the references.
Sure, that'd be
yes,
great.
Yeah.
penicillin's okay against some anaerobes, but the real anaerobe killers are Flagyl, and Flagyl's cheap and readily available and side effect profile is really very reasonable as well.
I have to be frank, though, I think it probably doesn't make any difference. I think they both work. And I think it probably doesn't make a difference.
I just know if I use it in somebody's going to say, why are you using that and why,
Sure.
where did you get that from? And
We'll try
I'd
to
like
help
to be
you
able
find
to
it.
say, hey, look, this is where I'm using it from.
Absolutely. And I'm glad that they would ask you, because I think someone who's paying attention enough to say,
And it's-
wow, haven't heard that, that's what we want.
Right, and it's certainly more inexpensive than Clinda, so it'd be a great choice to use. All right, thank you.
All righty, over
Oh,
here.
wait, I'm sorry, you use clindamycin
Penicillin.
and penicillin?
She
Well,
uses-
'cause-
You use pen, right?
She said clindamycin as well.
And pen.
Right. So the question is, why can't you use metronidazole and pen?
And
Metronidazole, I mean, I think most people would agree that the two anaerobe killers are clindamycin and metronidazole. And so if one's cheaper than the other, and they're both effective
Oh, I see what
anaerobe
you're saying.
killers, then I don't think you need to defend, we only use cliamycin.
I guess I'm
Clindamycin.
asking because I know quite a few endodontists, and like I say, I've never heard one of them ever recommend using metronidazole. That's not part of and that's their expertise, and that's why I'm wondering where the literature is.
I have it.
Okay, good.
Yeah. I think part of it, the old teaching was Clinda above the waist, metronidazole below the waist, which turns out to not be true. It's not magic that an anaerobe above the waist it isn't that different as far as the profile of efficacy. So I was taught that in medical school. I was taught that in my internal medicine residency. If it's something from here down, you have to use metronidazole. It's here up, you have to use clindamycin. Turns out that's probably not the case.
Is that applicable in the southern hemisphere?
I don't know. Everything goes down the toilet the other direction, though, in the other hemisphere.
All right, let's go over here.
With respect to viscous lidocaine in children, is there a cutoff of age of where you see the seizures and also a cutoff on volume? Like, for instance, you take a Q-tip and you put the viscous lidocaine on each little guy or each little lesion.
I don't think that anybody really specifically knows that, but they do know that some people have gotten into trouble. So the question is, what would be reasonable in terms of the symptoms of the kid versus using it as you've described? It's probably reasonable. I mean, but
Especially if they're
nobody
using
really
the
knows.
Q-tip idea. The key is not to have them slug it. You know, the swish and spits thing, it always ends up a swish and swallow, which is why that version is probably not a great idea. But if it's something where they could apply it with a Q-tip, it's great. It's like using calamine lotion and chickenpox. It's something to do, connect the dots using calamine. It doesn't actually do a lot, but that actually, the magic mouthwash does great stuff. I still get a thank you letter every year from a family that had foot and mouth. That poor mother, she had 4 kids that had hand, foot, and mouth disease at the same time. That magic mouthwash, everybody doubted it, made her life so much. I still get thank you cards every Christmas from her. So it's worth doing, and that Q-tip idea is brilliant.
Thank you.
All righty, we have another one here? Good.
Hi. I work in a clinic where I see most of my patients are homeless or either have kind of less than ideal living conditions where they live in hotels, motels, or in their cars. So I see a lot of rashes, skin stuff where I'm really not sure what it is, and I don't have the ability to do scrapings or, send them out or stuff. What is the best way to approach these things. I'm not sure if they're fungal, I'm not sure if it's bacterial, I'm not sure if it's a dermatitis. And also, another question I have is, I see a lot of ringworm that seems like it is almost refractory to ketoconazole. Any suggestions there?
Wow.
Well, you know, the environment that you described sounds like it's, you know, prone to scabies. And so if you kind of look in, is there something between the fingers or on the...
It's not scabies.
It's not?
It's not scabies, no.
All right.
So the problem with derm is it's hard to advise you on this, because derm is one of, no, I'm serious, because derm is one of those, you got to look at it. It's that picture's worth 1,000 words thing. And honestly, I work with a similar patient population as part of my patient population, and the rashes are rampant. They get eczema, they get fungal diseases, they get infestations, all kinds of stuff. And part of it is you having to get good enough at being able to at least say, this is an infestation, this is a bacterial source, this is a fungal source, to get it at least in the ballpark. Because the idea of throwing everything at all of them runs the risk of toxicities that they don't need to have. And so you are in a bit of a bind, and they can have more than one thing at a time. So part of it is to kind of make your best guess at that day, try what you think might help, and if it doesn't, then
try something
else. Because otherwise, and I completely understand that the situation, and I'll tell you, dermatology, there's a reason we take the picture and we hold it up to the patient. It's like, does this match? I don't know. What do you think it is? Derm's hard. Even dermatologists don't know sometimes. So I think it sounds like you're doing the best you can do, and I would focus it more on what's the general category here I think is going on, so that I can at least try to focus my treatment some.
And the question about refractory to ketoconazole?
Any suggestions?
What's the rash itself?
It looks like ringworm. I mean, it looks like
you're
a
seeing a
tinea.
circular
Yeah.
rash, and is it a single lesion or more than one?
It will usually start out as a single lesion and then start spreading.
Because there are a couple things you need to be a little bit worried about if it's refractory to ketoconazole. I'm not aware of any of the dermatophytoses being resistant. At least I'm not aware of that. It could be, but I'm not aware of that. I don't know if you've run across it in the database.
So maybe something systemic?
But I would worry more about something systemic. And there are conditions like T-cell lymphomas that look a lot like ringworm, that end up being patches that kind of spread around the body. And I would worry more about something systemic if it really is refractory and worsening. I would worry that it's not at all ringworm.
Okay, well, thank you.
Sure.
Thank you. Yes, sir.
So I'm the last person, looks like.
Gonna wrap up the conference.
Make it
no
good.
pressure.
Make it good.
This is just a follow-up of can we use metronidazole on oral. So if you look it up, oral anaerobic bacteria, metronidazole was, we used to use Bacterius fragilis, which they say it's bowel and below the waist. But if you look up oral anaerobes, normally it's Streptococcus and Fusobacterium.
Right.
But actually, Bacteria fragilis is listed one of the oral bacteria. So yeah, we can't use metronidazole. I don't have any research or anything like that. But if I just look it up, oral anaerobes and bacterial fragiles is listed one of the oral anaerobes.
I don't think that this would take very much research in the internet to find the support you need to show why that drug is perfectly acceptable in the mouth.
Yeah.
Definitely a lot cheaper than Clinda.
Yep.
Easier to take.
Very good. Well,
Yes.
Thank you, everybody.
thank you guys.
Thank you very much.
Thank you, Doctor.